Stephen, if you wanted to talk a little bit about the approach that UI Health takes. I know you have used a lot of data. If you want to touch on that and any other approaches you guys have.
Yeah, and just a bit of background. I used to be a systems engineer way back in the day and have a technical background. I can program and all, work with databases and all that. So when we started looking into homelessness, we started with a list of I just went to all the staff in the ED and found about 78 individuals. But that list has grown to over 7,800 now because we've done some data mining. We still don't screen for homelessness yet, but it has become part of the attending's history and physical. So we're relying on our attending physicians to document homelessness in their clinical notes now. And we have a social emergency medicine section, so we have an attending that can speak to his peers, and it takes a while to change workflows and things like that, but he's doing very well. On the data side, we found that what was most productive was we looked at the patient's address, what they registered with, and it was often a crisis shelter or a congregate living setting. And so as over time, we've gotten a little bit more facile in doing data mining. The last thing we were able to do now, and I don't want to get too techie on this, but often there's richness in the physician's clinical notes that we've been able to mine now. We do data parsing, and we're about to do some machine learning to be able to extract and identify those individuals that can often go unrecognized through our healthcare system. When it comes to social determinants, the challenge with social determinants is sensitivity versus brevity. We need, at least in our perspective in emergency medicine, we need to be as brief as we can, but we need to be accurate too. And just essentially, screening is an inefficient workflow process because self-reports are unreliable. You have to hire a pretty big workforce to be able to screen individuals. We did a little bit of a numbers game here to say, okay, if we want to get to universal screening just using some of our patient navigators, how many people would we need to hire? And it ended up being about 25 people. And we're not that large of an emergency department. So we are kind of stuck in this, how do we do this the most efficiently without being too intrusive too? There are a number of emerging companies that do things like they'll look at the census tract that somebody comes from. And census tracts are very constrained, homogeneous, very small geographical areas. And so the people that exist within it they have a lot of homogeneous characteristics. And so we thought, well, if somebody comes from this particular census block, could we offer them services? It gets more and more complex when you get into this because you do get into ethical considerations. You don't want to be Big Brother in this, but you also want to reach those people that are seeking help too. So I know it's a kind of an incomplete answer, but those are the two kind of the tension that we live in trying to bridge the gap and identify those individuals that have social needs and be able to give them what they need when they need it.